Good morning. Welcome, everybody. We're going to give it just a couple more seconds to let folks trickle into the Zoom platform, and then we'll get started. Great to see. Great to see the number of attendees continue to climb. Thank you so much for joining us. And Nancy, if we can advance to the next slide, maybe we can take care of logistics. So welcome, everybody. Just a couple of reminders before we get started. Live captioning is available. You can click the live transcript or CC icon on your toolbar to enable subtitles. We have American Sign Language interpreters with us today. You should be able to see Mallory on your screen. And for those who are interested in accessing the recording slides and transcripts, they will be available after the webinar on the Master Plan for Aging webpage. This is part of the Webinar Wednesday series. This is our kickoff webinar. The series will run March through December. And again, all of the materials and recordings will be archived on the California Health and Human Services Master Plan for Aging webpage. The series will feature state and local leaders with expertise in the subjects of aging and disability, programs and service delivery, and policy development. And we're really excited to have this series. We're saving time for questions and comments. So if you're joining us via Zoom, you can use the Q&A function on your toolbar. We've also have chat enabled. And if you are joining by phone, you can press *9 on your dial pad to raise your hand, and we will announce your last 4 digits of your phone number or your name, and we'll unmute your line to hear from you. And of course, if you think of additional information or feedback, you're always welcome to email the California Department of Aging team at engage@aging.ca.gov. Thank you so much. And I'm going to pass it off to Director Susan DeMorris.
Thank you, Maria, and good morning to everybody. We've got, 208 participants, 209. Thank you all so much for being here today. We're super excited to be relaunching the Webinar Wednesday series, and I can't think of a better topic than today's, focusing on CalAIM, as we are deep already into year 2 of the Master Plan for Aging. CalAIM, for those who are familiar already with this topic, is a major multi-year initiative impacting California's Medi-Cal program. And we know that no one will be an expert after one webinar, but we sure hope that today's webinar strengthens our network of aging and disability partners, providers, and consumers, and equips you with more knowledge. And we are committed at the Department of Aging and with our Cal HHS partners to continue convening webinars and other activities like the one today, so that we can all learn together and be well positioned to participate and contribute to CalAIM's success at the local level, the regional level, and the statewide level. So I want to thank, first of all, Sarah Steenhausen and Amanda Lawrence, who organized today's webinar, and they've been working very hard, and to all of our panelists who've done a lot of pre-work and preparation for today. I can't wait to hear from all of them, and I especially happy to introduce a key partner in the Master Plan for Aging, as well as CalAIM, and a whole variety of issues. Ellen Schmeeding, who was very active as a leader in the Master Plan for Aging in the Long-Term Services and Supports subcommittee work. And Ellen now chairs the California Commission on Aging. CCOA, as we refer to the commission, is a key partner going forward in all of this work. And I'm so proud to introduce all of you to Ellen if you don't yet know her.
Hi there. Thank you so much, Susan. It's a great privilege to be here. I'm welcoming you on behalf of the California Commission on Aging. We're the principal advocacy body for older Californians and a catalyst for change that celebrates Californians, all of us, as we age. We welcome the opportunity to partner with the Department of Aging to engage all of you stakeholders across the state, and we're proud to welcome those of you that are here with us today. We're also appreciative of ongoing stakeholder engagement efforts to educate about and solicit input. Things are moving so rapidly with the master plan, and having your dedication and awareness of what's happening and participating means everything to the effort. One of our top priorities is developing innovative long-term services and support solutions. That's one of our top priorities for the California Commission. And we look forward to the continuing developments in this area. And I can just share with you from being in San Diego and working on long-term care integration for 20 plus years. We had numerous pilots. Finally, we were able to move forward with integration as CalMedi-Connect with our Healthy San Diego health plans. And we worked to integrate IHSS, in-home support, MSSP, CBAS, and for the first time brought in skilled nursing facilities. We worked so hard to truly coordinate care through CalMedi-Connect, and now seeing CalAIM take the lessons learned and further develop this important program that includes community supports and enhanced care management, mirroring many of the benefits that our integrated program PACE provides. So very excited to see these efforts enhancing care for those on Medi-Cal. And our dream, one of our dreams at the Commission, is that this will also lead to innovative integration for Medicare middle-income recipients as well. So thank you so much. I'm also looking forward to listening in today and learning more about CalAIM. Thank you. And now Sarah Steenhausen, please take it away.
Great. Well, thank you so much, Ellen and Susan and Maria. It's so wonderful to be here. I am just going to provide a few kind of context setting background information on CalAIM, and specifically focusing in on the elements related to enhanced care management and community supports, because this is really where our aging and disability partners can leverage their strengths to be critical partners in the implementation of CalAIM. Next slide, please. So many of you, I'm sure, familiar with the broad goals of CalAIM, but they're really three-part goals. One is first to identify and manage the comprehensive needs that Medi-Cal eligible individuals have through really a whole person approach to care. And this is critical because this is really where a lot of the system transformation comes in, trying to better align services across medical and social service delivery systems so that people don't have to just consider needs separate from one another. We know that housing and that food and a number of other social drivers impact a person's health. So this is the state's effort to try to better align services through a whole person approach to care. Second key goal of CalAIM is building off this new kind of whole person approach to care. The hope is that this will improve health quality outcomes and reduce health disparities, and particularly evident as we've seen over the past few years with COVID and how it's impacted communities across the state, including Black and Latino and Indigenous populations. Hopefully that by developing these new strategies, we can really start seeing some new improved health quality outcomes. And then finally, the goal of the state is to help make Medi-Cal a very seamless and consistent system that's available statewide. So right now, if you're living in a rural area, you might be challenged with getting the same services and supports as somebody who is in Los Angeles. The state is really trying to make it so that there's a uniformity, less complexity associated with Medi-Cal so that you can be assured the same benefits regardless of where you live. So this is kind of the very broad overview of CalAIM. And I want to now move into the focus on enhanced care management and community supports. So as I said, these elements are really foundational to this whole person approach to care by blending really complex care management with services that address a person's social needs. The hope is that you really can start seeing some improved health outcomes for the population served by Medi-Cal. Next slide. So I want to start with enhanced care management and explain what it is. Essentially, enhanced care management is a whole person interdisciplinary approach to care that addresses a person's clinical and non-clinical services needs. And this is particularly for members who have high level of need. So the way that the services are delivered is that it's through a systemic coordination of services and comprehensive care management across the continuum of care. So again, recognizing that people don't just have needs in the medical care delivery system, how can they better provide more intensive care coordination across the continuum of care? This is a very high touch and person-centered approach to care management, care coordination. And it always has reminded me a lot of the model that we've seen grow in the MSSP program, the Multipurpose Senior Services Program, that has such a high touch impact on people who are eligible for it. But what I really think is important to note is that with enhanced care management, it is not necessarily something that every Medi-Cal beneficiary will be able to access. You need to fall into what they call a population of focus. So as long as you meet the target population need, you can then be eligible for enhanced care management. So you'll see on the screen that they have identified populations that have high needs, including individuals experiencing homelessness, adult high utilizers, individuals with serious mental illness or substance use disorders, people transitioning from incarceration. And then finally, I think where a lot of the opportunity is for older adults and people with disabilities is in these final two populations of focus, which are people who are at risk of institutionalization and living in the community, and people who are in residents of nursing homes but wish to transition to the community. So these are people that would fall into this category of populations that could qualify for enhanced care management. And I'll talk more a bit about what this means and what next steps are for building capacity in this system. So the next slide is focusing in on community supports. And as I said, the state's really trying to emphasize the whole person approach to care. So if you have more intensive and high touch care coordination, you have to make sure that you actually have access to the services that people need to get coordinated. So the state is hoping that Medi-Cal Managed Care Plans will offer a variety of or all of these community supports. As you can see, there are 14 defined community supports, ranging from housing transition and navigation services to housing deposits and tenancy and sustaining services, short-term post-hospitalization housing, recuperative care, rehabilitation services, caregiver respite, personal care services beyond what's covered in in-home supportive services program, nursing facility transition and diversion to assisted living or transition to a home, as well as nutritional support, meals, medically supportive food. And then finally, sobering centers, asthma remediation, and environmental accessibility adaptations, which are commonly referred to as home modifications. One thing that's really important, if you could just go back to note, community supports are not mandatory for Medi-Cal Managed Care Plans to provide. So the state is trying to highly encourage plans to develop their proposals so that they can provide community supports, but at this time it is not mandatory. So that's something to consider as we're moving forward right now. But if you move to the next slide, I'll talk a bit about the interaction between enhanced care management and community supports. So starting with enhanced care management, it's being phased in by the different populations that I outlined, target populations. So this year, the managed care plans are starting with the homeless and the high utilizer populations, as well as people with serious mental illness and substance use disorders. And then next year, Medi-Cal Managed Care Plans will start providing enhanced care management to people transitioning from incarceration, people who are at risk of institutionalization, and people who want to transition from nursing homes to the community. So again, managed care plans are required to provide enhanced care management to these populations of individuals, but it's getting phased in over these next 2 years. In contrast with community supports, as I said, it's voluntary for managed care plans to offer these services in the communities. They're being encouraged to offer them, and there is information on the Department of Healthcare Services websites about which community supports are being offered by which plans and in which counties, but they need to apply to the state to obtain approval for providing these services. They can add or remove services at defined intervals. So every 6 months, a plan could decide to add a new service. And every year they could decide to remove any of those services, but they have begun offering these in 2022. The state is hoping that together between enhanced care management and community supports, we will have a statewide network with these services in place by 2026. And they are saying that this is kind of their vision of what our managed long-term services and supports delivery system will look like, that again, aligns with that vision of addressing a person's need across the continuum of care. But what's really important for the conversation that we're about to have is that this doesn't just happen magically. You know, managed care plans don't just snap their fingers and decide they want to start providing these services. In fact, they rely on all of you as community partners to contract with to provide these services. But that too involves a lot of upfront work in planning and capacity building. So if you go to the next slide, I want to highlight some significant opportunities through a program called Providing Access and Transforming Health. There was funding provided in the Home and Community-Based Services Spending Plan, up to $100 million that could be used for a variety of purposes, one of which is providing a funding opportunity for community-based organizations who wish to become providers either through community supports or through enhanced care management for different types of delivery system infrastructure investments to encourage local partners to build capacity so that they have the ability to provide the community supports and the enhanced care management that's envisioned by CalAIM. And if you go to the next slide, I've outlined a few of kind of some of the use that this funding could be used for. They're recognizing the need for recruiting workforce and onboarding and training workforce, IT and data sharing. We could talk a long time about how all of this CalAIM vision requires a huge infrastructure of internet, IT development and data sharing. That's a tremendous need. So resources for that and for building capacity in the providers and for general delivery system infrastructure investments, such as care management systems, closed loop referral systems, and billing as well. What's important to note at this point is that the department has a lot of different resources on their website at dhcs.ca.gov. But they haven't yet released the application or the funding requirements for this PATH program. So today is really timely because we want to kind of put it on everybody's radar to be watching for it, so that when they come out with their announcements and their information, that you and your organizations in your community are ready to apply for it. And we at the department are committed to working with you as partners to provide as much technical assistance as we can along the way to make it easier. Next slide, please. So these are some resources. And again, these slides will be available to everybody. It's a very, this requires a lot of work, a lot of planning, and there's a lot of resources on the department website to get from here to there. One example is, in order to contract with Medi-Cal Managed Care Plans for these services, your organization needs to have a national provider identifier. So that means that you're qualified to provide services in the Medi-Cal program. So the department has a lot of information on their website about how to go about doing that, as well as policy guidance for both community supports and enhanced care management. Next slide, please. So that was a lot of information that was given to you in a very short amount of time, but I think it kind of frames the conversation that we're going to have for the next hour with our tremendous panel of partners. But I think the main questions to really highlight in this panel discussion are, what are some of the best practices in building partnerships? where do you start? How can local community-based organizations engage with health plans, but also how can they engage together so that they can build networks to make it easier for managed care plans to contract with you? Because managed care plans are going to have a hard time, knocking on every provider's door to develop contracts. So I think there's a lot of opportunity for aging and disability partners to work together to form collaboratives and with other community-based providers that will be providing other services in CalAIM. So with that, I want to close it out and turn it over to Sarita Mahanti, who will be facilitating the conversation. Thank you.
Thank you so much, Sarah. It's a pleasure, and really, really excited to be part of this esteemed panel. I do want to thank the California Department of Aging and the California Commission on Aging for allowing me to moderate the panel today. And, I think you'll see as we're having a dialogue today with these panelists that you'll see the dedication and commitment to partnerships as we really try to advance our efforts around healthcare and community integration for older adults and those with disabilities. So really, again, I think it's going to be a very informative, worthwhile, engaging discussion. And we do look forward to seeing your questions and comments throughout the presentation. We'll definitely get to those after we hear from our panelists. So with no further ado, I'm going to go ahead and start introducing our panelists. So if we could have them on the screen. We'll go in alphabetical order here. And let's see here. Do we have Michael Costa? He is I'll introduce him first. He's the Executive Director, California Association of Area Agencies on Aging. So welcome, Michael. Next, we have Eli Gelardin. He is the CEO of Marin Center for Independent Living and the chair of the California ADRC Advisory Committee. So welcome. Ben Haragi, and he is the manager for behavioral health and community support services for Inland Empire Health Plan. So I believe Ben, I think we'll have you're there as well. Thank you. And Christy Kolinsky, who is the team lead for the Office of Network Advancement Administration for Community Living. So welcome, Christy. And Anwar Zuhaid is the vice president for Partners in Care Foundation. So we have a breadth and depth of expertise amidst us. So I'm going to just dive right in, and I'm going to start with you, Ben. I think, as a manager of community supports and services at Inland Empire Health Plan, you have a tremendous amount of experience in engaging community partners in helping older adults and people with disabilities access a wide range of services across the continuum. What lessons have you learned in these efforts, and what recommendations do you have to aging and disability partners across the state?
Good morning, and thank you for having me. The first lesson we learned right away is that we can't provide all these services that the community needs. We definitely know and understand that our partners have the expertise, the experience, and the know-how to really serve the community. They have the expertise in certain services, whether they be housing and homeless services, whether they be independent living services, transitioning services. So we knew right from the beginning that we needed to partner with these agencies, and we did. We partnered with several organizations back in 2005. I would say was the beginning of partnering with a lot of organizations through different collaboratives that we started and still support to this day. The Inland Empire Disabilities Collaborative, the IEHP partnered network meeting that we host, monthly meetings. And I think that was the initial start of getting folks together so we can network, collaborate, work together, get to know each other. But knowing who's out there, understanding what services they provide to the health plans, I would say we have to know our community, we have to know our providers, our nonprofit organizations, county organizations, our independent living centers, and of course our Aging and Disability Resource Connection, and the AAAs, the area agencies on aging also. We have to know those partners and their expertise and what they do. And I would say the second part of that would be that we need to learn how we operate, because it really helps us to understand how one another operates. I think it, to some folks, healthcare might be, difficult to understand, but really, once you get to know that your local health plan, you'll see that what they do, their services are we believe in the same things. Definitely, we have an interest in serving the health and social needs of the members. We have an interest of supporting people in their home, and supporting them through that, and supporting them through transitions out of long-term care and housing, and addressing housing and homelessness. So know that health plans are definitely interested and invested in social determinants of health. And that includes everything that we've discussed here today, the master plan for aging. But I would say we speak the same language also. We just use different terms. We're speaking the same thing though, when we say person-centered care, or whether we say independent living or self-determination, we're all speaking the same, just using different terms. And I think that's helpful to learn also those words and terms that we use to really find that connection and how we can work together. But highly encourage networking and developing those relationships.
Great, Ben, thank you. And I think you highlighted, I think the semantics, the language, we all do speak the same language, even with the different terms. I think it's a really important call out. So I thank you for that. And I know we'll have some questions for you. I'm sure I'll have some, and others I'm sure in the audience will as well. So thanks again for answering that question. Next, I'm going to turn it over to Anwar. Anwar, thank you for being here. And as Vice President of Partners in Care Foundation, you're also a CalAIM and waiver provider. You have a lot of experience building capacity, I would say, around the health plan and long-term service and supports arenas, and particularly as we think about home and community-based service networks. What do you think is really needed to make aging and disability successful partners in kind of the efforts you've been engaged with?
Yeah, well, thank you for having me. And
Did Anwar freeze? Okay. All right. Thinks we might have lost Anwar for a moment. If so, maybe with that, if it's okay, why don't we go ahead, and if it's okay, if I can go to you, Eli, for the next question, then we'll circle back to Anwar when he returns. So, Eli, thanks for being here. As the Executive Director of the Marin Center for Independent Living, you've done a lot, to develop partnerships with aging and disability, as well as, with local community partners. So what kind of experience can you talk about that, about engaging, particularly the healthcare sector, and what is it that you need? Like, what do you see as the core opportunities to succeed in these CalAIM capacity building opportunities?
Thank you, Sarita, and hopefully I don't freeze once I start talking. So I'll move my head to make sure I don't. There's so much in the space of relationship building and partnership development, and I just start by saying that it's really earnest work. There's kind of the speed dating, or in and out fast food model, and then there's the slow food movement, the farmers market, cultivating relationships over time. And I definitely think when you're looking to partner with the healthcare sector, public-private partnerships between like independent living centers and AAAs, you really have to start by meeting your peers, your fellow leaders, and just starting with conversations around, why partner? What do you hope to achieve? Understanding each other's languages and cultures, building incrementally off of, pilots, establishing protocols and procedures for your teams to initiate, and then kind of elevating and scaling that up over time. Our work really in this space started back in 2014 when we began talking about this. What is this aging and disability resource connection model, and how can the AAA and the Independent Living Center work closely together? That kind of evolved, and Marin CIL was invited to participate in an incredible accelerating business capacity initiative led by our local community foundation and collaborative consulting, where we built our capacity as an organization to partner in the healthcare sector, understanding what do we bring as value to healthcare. Why is person-centered care so important to achieving the AAA of healthcare? Lowering cost, improving health outcomes, improving patient experience, and then kind of doing environmental scan work, identifying where our value proposition fit in the healthcare ecosystem. And that led to a series of additional partnerships before we, got to managed care, primarily working with our federally qualified health center around a pilot to address complex, medically complex patients at the FQHC level, which ultimately led us into conversations with CalAIM. My point being that it really is steps incrementally along the way, building a really strong foundation internally as organizational leaders with your teams, building their skill sets up, building that trust and relationship with your public and private partnerships, other CBOs, other players in your local healthcare system, and then pursuing opportunities for funding, which we've been successful in. We're still early in the CalAIM process, but again, we hope to leverage those partnerships, those MOUs, those relationships we've developed in the other spheres to pursue opportunities in CalAIM.
Eli, thank you. That was really quite insightful, and I think you highlighted something that I know will resonate with our panelists as well as I think the audience about that one, this is an incremental process and it's a series of steps, and namely that this important how do you build that trust, how do you build those relationships, that's kind of the foundation of this work. So I really appreciated that insight, so thank you. All right, so next I'd like to pose a question to Christy, and then Anwar will come back to you. Thank you for being, I'm glad you were able to join us. So Christy, as you're the Administration for Community Living, or ACL, you're a lead and have been supporting aging and disability partners, in developing these relationships with the healthcare sector, particularly in its funding support and of the Aging and Disability Business Institute, or it's the ADBI as an acronym. How do you see this and other federal efforts really aligning now with CalAIM, and how we might take advantage of these resources at the state level?
Great. Thank you, Sarita, and thank you to CDA for the invitation to participate on today's webinar. It's great to see the crowd that you all have on the line. So I have the privilege of serving as the project officer for California's ADRC No Wrong Door CARES Act grant. I saw there was a question in the chat about how does the ADRC system interface with CalAIM. That's a great question, as well as a grant to Partners in Care Foundation to strengthen their infrastructure relative to their role as a network lead entity. And I'll share a bit more about what a network lead is in just a moment. So as you noted, I sit within ACL's Center for Innovation and Partnerships, specifically as a team lead within our Office of Network Advancement. So our office houses the ADRC No Wrong Door initiative, as well as what we've traditionally called our Business Acumen initiative. And that's an effort that, in collaboration with private foundations and other national partners, provides aging and disability networks with the tools that they need so that they can successfully partner and contract with the healthcare sector. So we know that AAAs, independent living centers, and other aging and disability CBOs in our network are expert at delivering social care services in a person-centered manner, particularly for those high need, high cost populations that have complex health conditions coupled with functional limitations. We're known and we're trusted in our communities, and we've been addressing social needs for decades. This is our wheelhouse. So CalAIM presents a terrific opportunity for CBOs like AAAs and ILCs to partner with managed care plans to address those social needs for enrollees, particularly through the ECM and the community supports components. So nationally, we know that the Aging and Disability Network is contracting with healthcare to provide services. The most recent request for information, which is a national study that the Aging and Disability Business Institute, which is housed at US Aging Fields, along with the Scripps Gerontology Center, found that about 44% of our national Aging and Disability Network is currently contracting, and another 12% are pursuing contracts. So clearly there's movement in this direction. And those survey respondents include AAAs, ILCs, and other aging and disability CBOs. We're also seeing that the most common services that are provided through contracts really line up well with what's included in CalAIM. So those are SDOH assessment, case management, LTSS assessment, nutrition programs, and then home care. And additionally, the most common type of healthcare contracting partner are Medicaid managed care plans. So there's already a wealth and a breadth of knowledge across the National Aging and Disability Network in this space. So to be sure, healthcare contracting requires a significant culture and business change for many CBOs. And I think Eli really touched on that, and Ben touched on it a bit in his remarks as well. So organizations that responded to that same national study also indicated that there were some really significant positive changes that resulted from this contracting. So a couple of them were positioning the agency as a valuable healthcare partner. Another one was increasing the number of people served. So by having these healthcare contracts, they were able to enhance their mission and increase the people who they were serving. And then, of course, obtaining funding from new sources. So there's never enough money, I think, from our formula, from our discretionary grants, from our other sources of fundraising to meet the need in communities. So having those contractual arrangements with healthcare are really important to serve more people. And of course, that contributed to enhancing the organization's sustainability overall. I also want to point out that that same survey found that the proportion of CBOs that are contracting as part of a network, so versus as an individual independent organization, has doubled over the past 5 years. And that's really in line with what we've been supporting within ACL. We know that not all community-based organizations are prepared to enter into a contract with a healthcare entity. There are a number of challenges like legal review, privacy requirements, technology requirements, financial management systems, and they can be burdensome for some community-based organizations. And healthcare entities have also indicated that they prefer a single contract with a lead organization that can manage these logistics like compliance, performance, quality assurance, billing, etc. So what we've really tethered our support at ACL around is the component of a network lead entity, that concept, or a network hub. So this organization serves as a backbone for a broader network and offers one-stop contracting for multiple interventions. So if you think about a hub and spoke model, the NLE, the network lead entity, sits in the middle, and they handle the business operations and the administrative oversight for contracting. And then the spokes are the various community partners that can deliver an array of services across a geography. So this is a more efficient model in many respects. It allows all CBOs within a geography to have the opportunity to participate without those barriers that I noted earlier that are often associated with contracting. So as I mentioned earlier, we're funding 12 network lead entity grantees across the country, one of which is Partners in Care Foundation in Southern California, where I know Anwar is, though I know their network extends across the state outside of the southern part of the state. But I do encourage you to think about a network-based approach as you think through how you can most effectively partner with CalAIM providers and best ensure that individuals have access to services that holistically address their needs. We do have some technical assistance that we provide on network development, so please feel free to reach out to me if you have an interest there. Speaking of technical assistance, I do want to highlight the role of the Aging and Disability Business Institute. Sarita, you mentioned that in your question. That's housed at US Aging, which is formerly the National Association of Area Agencies on Aging. We support the Business Institute, as does the John A. Hartford Foundation, and the SCAN Foundation here in California supports it as well. So whether you're contracting as part of an individual CBO or a network, the Business Institute has a ton of resources available to support your partnerships. I'll drop the link to their website in the chat in just a minute, but it has resources that are available for organizations at a variety of levels of sophistication. So they have assessment tools, contracting templates, checklists, and more. They regularly host webinars and even offer opportunities for more in-depth technical assistance through learning collaboratives. So for example, they're hosting one now on financial acumen. So I just want to wrap up by saying that I think CalAIM offers an incredible opportunity for AAAs, ILCs, and other CBOs to be engaged in meaningful partnerships with the Medicaid managed care organizations to provide the services that are core to what you all do each and every day. This is really exciting delivery system transformation. And I know at a federal level, we're watching it and are eager to see how it all unfolds.
Christy, thank you so much. That was wonderful, perfect, because it really, you offered some really important information about the Aging and Disability Business Institute, about the network lead entity, just about the fact I thought that was really important to recognize that, you're seeing a growth in contracting based on the survey that the Disability Institute, Business Institute did. So that is, and it's a lot of work. So, and technical assistance seems to be available. So that's good to hear. So, well, with that, actually, Anwar, now that you're back, I think this is actually a nice segue, given Christy's framing, and also the fact that you are a network lead entity. And so I'd love to hear your thoughts again on the question I posed earlier about, working across health plan and long-term service and supports.
Excellent. And sorry about that technical difficulty. I hope my frozen frame was a good one. So to answer your question, Sarita, I think what we need is ongoing communication, education, and engagement with stakeholders, just like this one. Providing ongoing training and education, educational updates on CalAIM and how we can offer providers ways to coordinate with the local care, managed care health plans, discuss being ECM providers, community supports providers to help integrate the services that we provide to our community, learning more how aging and disability providers can get involved with CalAIM, both directly and indirectly, especially our county AAAs, our CBAS centers, our MSSP providers, and other home and community-based service providers who are really the experts in providing services like enhanced care management and community supports. And just a reminder, the CalAIM initiative actually mandates contracting with community support or community-based organizations who are the real ground level experts. We have worked so hard for many years to be really recognized as the leaders who really make the most impact in addressing the key health disparities. We are the experts in addressing social determinants of health, but not only stopping there, also leading the coordination of the clinical and health needs of our communities. Becoming an enhanced care management provider or community supports provider is a great way to expand the agency's scope, build an integrated system of health deliveries, be part of the solution to close the many gaps that we have in our health delivery system, and be part of the design to optimize the care coordination throughout the health delivery spectrum. Build on the talent and the knowledge that has been the staple of our agencies in our communities for many, many years, and maintain that local knowledge and expertise, and complement other wraparound services that you may be already offering. Also helps enhance a more diverse profile of the services your agency provides, along with the ability to utilize CalAIM programs to expedite service delivery. Remember, this is all made easy with the abundant support of both the state and the managed care organizations through path funding and incentive funding, which also help support your agency in building the capacity, funding, staffing activities, training, and the purchase of IT-related equipment. So that's a huge help. And you can see all the effort and funding that's being provided to all stakeholders to make this initiative work. And also the managed care health plans really do provide so much support, hand-holding and training. So it's not just saying, here's a contract, goodbye, we'll see you later. And just to kind of, I've been talking to really the community-based organizations, but just wanted to point out for our friends at the local managed care health plans, please make sure you have a diverse pool of enhanced care management and community support network providers, especially enhanced care management. Don't just extend ECM contracts to your currently contracted clinical providers because it's just easy. In order to help really contribute to the success of CalAIM, I feel that managed care organizations need to build a network of providers who can really address the diverse needs of our population of focus, including homelessness, SNF diversion experts, social determinants of health experts, clinical care experts, mental health experts. I also want to just end by offering my availability for those who really want to talk and learn a little bit more on how we became CalAIM coordinators and providers. And to Christy's point, yes, we are a statewide network, and I'm happy to discuss that with any stakeholders as well.
Fantastic, Anwar. And you know, I think your initial, and I think throughout your comments, the area around ongoing engagement, I think, has resonated with some of folks in the audience. I've seen some comments in the chat, like, you know, one from Marty Omoto, who said mistakes will be made or things overlooked, but ongoing engagement can help solve problems and mistakes. You know, we can focus on urgent, unexpected, unintended consequences or address an unexpected crisis. So I think, you know, that is, I think, critical. And no, I think you highlighted, I think, the important aspects of one. The other thing I think we should talk about more is about the, you know, the network building that plans need to accomplish, and the diverse network building that is necessary to address the diverse needs of the population. So that was something that I also took away. So thanks again for that. And well, great. Now, so next I have Michael here. I have a question for you. As you know, as an executive director for the California Association of Area Agencies on Aging, excuse me, or AAA, you are playing a leadership role in building capacity across the Area Agency on Aging partners. What are some of your thoughts on the roles of that area agencies can play moving forward, especially as you've heard the comments from the other panelists?
Yes, thank you, Sarita. It's really good to be here. I think that CalAIM is a great opportunity for AAAs and their community partners to kind of attain the prime directive for AAAs, which, you know, was established back in the 70s, and it's basically still the prime directive. And that is to help vulnerable older adults maintain their independence and live in the community. And you know, over the decades, there have been a number of services, core services, that have been given to AAAs to perform, starting with the Older Americans Act, continuing with the Older Californians Act, and then a whole series of Medicaid waivers and other federal programs. So that AAAs today and their partners, actually, I would argue, are already offering a number of community supports. And I'll just take a couple of examples. I think if you look at medically tailored meals, medically supportive meals, home modifications, homemaker and personal care, housing supportive services, housing referral and a replacement and caregiver respite services, you're really talking about, with a little tweaking at points, services that are already being offered by the AAA network and their contracted partners. The challenge here is that there is no uniform service offering across California. So AAAs vary and their partners vary by county in terms of what they actually, actually offer. And so one of the reasons I think I was hired is, and I'm going to hear about it at my annual review, is what have I done to educate my members about the opportunities out there, not only with CalAIM, but also with Medicare Advantage and other opportunities. So we're taking steps now internally. We're going through an education and project around the opportunities, which then will lead to a business planning project that really will help us as a group of AAAs make a decision about whether or not we should go into network development. And we're going through this process, and it's a very stepwise process, because we want to make sure we make a good decisions around that, because as Anwar can say, developing a network takes a lot, and there are a lot of surprises that happen along the way. And so we want to do that. But at the same time, in the short run, we need to implement a TA project, I think, for our members to help bring a lot of them up to speed around contracting and having that conversation, and also making sure their service delivery is at a point where they actually have something to negotiate with the healthcare plan. So we're doing that as well, because that's the principal challenge. How do we have a service offering that we can bring to managed care that says, okay, it's logical to contract with the AAA and their community partners. It's very much a joint effort, by the way, because we have established relationships with a number of community partners that have existed for decades. And I'd make the argument that we're already a network. We are a social service delivery network that's there. The challenge with healthcare is over the decades, since the 70s, you've had a development of a social service network represented by the AAAs and partners. And you've also had a development of the healthcare network. The healthcare network today, the provider network, is very different than it was 40 years ago. And they both developed over time without really having a lot of crosstalk. So getting to the language issue, I think it is important for us. It's a way of us having a conversation with healthcare and really understanding where we are thinking along the same lines, but also where in subtle ways we have different attitudes. And I'd use the term case management as an example of that. If you talk to a healthcare provider and ask them what they mean by case management, and you talk to a social service provider, you have a somewhat different definition. And I'd make the argument that if we're going to really make headway with healthcare plans and providers, that we have to come to a mutual agreement about an expanded view, expanded definition of case management that really allows for a continuum of care, a continuum of services that the people we care about, which are older adults, that actually provides that continuum. So that's going to be a dialogue that's going to take some time. And that's a challenge, but I think of it as a success factor, because I think it's something we can do. There is a failure factor in all this. And I come out of a healthcare background and spent a lot of time negotiating with health plans around getting adequate reimbursement and payment for new services. And I think there is an issue there when talking to plans initially around a new service or a new contracted service. And that's really, how do you establish a reimbursement rate and a payment rate that actually captures the value of what you're providing? And usually it takes a little time because there's not very good data at the start. People are going after or using guidance that perhaps isn't apt for a particular thing, say a meal. And so there's going to be a dialogue there. And I would encourage folks who are in that discussion now with or plan to be with their local healthcare plan, that it's very important to do everything you can to obtain adequate payment for the services you're offering. I will never advocate to my members that they go in and provide loss leader services. I just don't think CBOs can do that, and AAAs can do that. And we always have to be concerned about that. And I think that's an issue that has yet to be probably fully realized by folks.
Thank you so much, Michael. Yeah, I think you've highlighted on things like some of the challenges, the opportunities, what kind of supports AAAs and other organizations really need to be able to do this effectively. I thought it was fascinating, interesting to, how do you even two things about case management and how you define that, kind of being clear on that. And I know that CalAIM, in the enhanced case management model, and others have those kind of definitions, criteria. And then the other thing that I think comes up a lot, which I know is probably a lot of folks are trying to figure out as well, is about the how do you define value, and how do you measure that? How do you substantiate then the rate setting and all of those things based on the value of the service that's provided. So, well, I can tell you, you all have stimulated some active dialogue discussion in the chats. I will encourage, actually, we are actually for this webinar, encouraging, if you want to state your question, audience participants, you feel free to raise your hand and we will seek you out and have you ask the question, because we want to make this as interactive as possible. But before I go to some of the questions that the audience has posed, any questions that panelists might have for their fellow panelists on this call, on this webinar, before I go to the questions in the chat? Or are we ready to go? Just dive right in. Okay, well, let's do that, because I think it'll engender some more dialogue. So, one of the questions that actually we're seeing a lot of questions on how to build a network at the local level. Kind of reinforcing, I think, the technical assistance, the importance of technical assistance. And so local, partners would be well suited to engage with other local providers and find out whether there is what is the local network, currently, and how they might engage, while also exploring resources through the Aging and Disability Business Institute. So maybe, I don't know, maybe I'll start with you, Christy, and others can chime in. Like, how do you really start to envision or build this kind of local network with other partners, as you even discussed, even creation of these hubs? So love to hear more from you on that.
Yeah, and I think I would defer to Anwar on the on-the-ground real-life experience of making this happen, because I know Partners has done so successfully. But I would note that, I think having that administrative infrastructure, so having an organization that has the resources, I think the kind of, some of it's too is leadership approval and leadership direction that is willing to take on that role. I know it's harder in some organizations than others, especially depending if you sit, within a county council of governments, or what type of organization you are. That can be more challenging. So I think some of it is resources, leadership support to take that on, and just the ability to develop that administrative infrastructure that allows for the invoicing, the payment, the quality pieces. So is there an organization that's part of the broader catchment area that can be elevated to fill that role? And then so much of it too is partnership development. And there's different types of models in terms of how this works. Some are more formal, some are less formal, some have more of like a federated model. But that partnership piece, where that core organization, that central organization has a really specific role, but they're working in tandem, in lockstep with their partners. They're not directing their partners. It's not an authoritarian type of relationship or a vendor type of relationship where I'm the network lead entity and you are my vendors doing this work, but it's really a collaborative relationship. And I think that that process is equally as important in terms of making sure that the network is all on the same page and everyone is feeling supported and like they're part of something bigger. It's equally as important as the administrative pieces that get built into kind of how that network lead functions. And Anwar, I would defer to you on how that's happened in within Partners in Care.
And I think you really captured everything really well, Christy. And Partners in Care, just like Michael mentioned earlier, it's been quite difficult when we started this over 10 years ago. And we do have a statewide network of community-based organizations now. And we also have an active ECM network right now in the San Diego with a great, wonderful partner, Kitty Bailey, in San Diego, and also in the Inland Empire. And we're establishing one right here in Los Angeles, working with a good friend of mine that has a lot of expertise in adult day healthcare center, Amanda from Total ADHD Solutions. And one of the key things here is really making sure that we have experts that have always been able to provide services and have a really great track record in providing services, but also working with the managed care health plans to make sure what is our target population for this specific area. What is the volume expectations, because we need to also maintain the actual volume and really then target that and work hand in hand with the health plans to really make our network successful. And they have been successful. And just like Christy said, we have worked on a very sophisticated Salesforce ECM software system that can provide encounter data. We have a very sophisticated engagement center led by my colleague Esther Civilian. And because of all that technology and all that knowledge and even the relationships we have with the state, the managed care health plans, and even the plan associations is really made us key to a successful network service provider.
That's great. That was very helpful, and I think just to hear how kind of logistics of the approaches you've taken in developing these networks is key. I guess Ben, as from the health plan side, as you hear about these networks and kind of the hub and spoke concept that Christy referenced, what is the health plan? Kind of from their vantage point, what do you see as the opportunities or the questions as about these network lead entity models? I think you might be on mute. Thank you.
Thank you. I definitely appreciate the support that's being provided to various organizations, because it is different to some folks to contract with health plans, may not be familiar with NPI numbers, may not have the technology available to ensure that emails are encrypted and things like that. So submitting claims and encounter data and all of that can be sounds intimidating, but really it's just having the right technology. It really is. I think at first all those terms and words and are foreign, but really it's just about having a secure system in order for us to communicate. So taking advantage of all those programs, the PATH program, the Business Institute, and the relationships that here, those folks who have already pioneered or have those existing relationships with health plans, and talking to them to share their experience with other folks would be helpful. And of course, health plans can also share our experience with others. But we were fortunate to partner with Rolling Start Local Independent Living Center, who is also the designated Aging and Disability Resource Center. So I think if you have those partnerships also with AAAs and ADRCs, that would be a good start, good place to go to find more support in those forming those relationships and getting ready to provide some services.
Sarita, can I add something there?
Of course, please.
I was thinking about what Michael was saying about identifying cost for services and not wanting to lead the network into a loss leader. And I used to work with evidence-based programs, and I know that was one of the most challenging things was to identify a cost for the program and then differentiating between cost and price. Because they are different. And I think it was June Simmons, who's Partners in Care CEO, who would say no margin, no mission. So there has to be some margin that gets built in as well. Anwar's nodding because he's heard that before. And so then I'm wondering from a network perspective, if you can actually, because of the economies of scale that come with the network. So you have one organization that has to house the technology, the software, the payment and invoicing, the legal review for contracts, things like that that cost a lot of money, but that everyone can kind of feed into, that then drives down some of the per cost or your per capita price on your interventions as well. And that's a way to make the aging network and disability network more competitive as well with their partnerships with the MCOs. So just wanted to make that connection.
That's great. That's great. Michael, I don't know if you have any additional thoughts to that comment, since I know Christy was referencing some of your kind of next steps as you're working with the area agencies on aging.
Yeah, I mean, I think the immediate thing is to help people understand the opportunities, and then help them make decisions about what they want to do individually, and then what we want to do together as an association. And then and providing TA initially, because some of the AAAs are already out contracting for CalAIM. There's one that is doing ECM and meals, so that's already happening. Well, the ECM piece is in development, but and then there are others that are thinking about it, and then there are others who probably will never do it. So we're trying. I think this planning project will actually really lay that all out, because I have done network development work in the past, and it's a big decision, to decide whether or not you want to do it yourself, whether you want to be the lead agency, whether you want to hire an MSO to do all those other things that lower the cost. As Christy talks about, there are a number of different models that you could use to minimize the cost to the participants. And that's what the business planning project for us will help identify and will make decisions on. It does appear that a lead agency model, and I think Anwar would agree with me on this, is a pretty good way to go, all things considered. But
yeah, great. No, thank you for that. And Eli, I was reflecting back on your comments about capacity building. You said you went through a process of kind of assessment and building that capacity. So as you're hearing about as we move in CalAIM and ECM and doing what would be some of the things you learned in your capacity building process? I even think about and I'd probably ask this question of all of you: data exchange, collecting data, being able to share it across your constituents, your stakeholders. So if you could shed some light on how it's looked like for you through your lens.
Yeah, thank you, Sarita. And for our organization, it really started with a self-assessment. What are our strengths? Where are our gaps? Obviously, being a peer-led, person-centered, independent living center, we have some value just from the lived experience, and our service delivery model is awesome. But to your point, how we collect data, how we track, what are our confidentiality agreements and compliance standards to meet the needs to contract, whether it's with a health plan or a FQHC, or even share data in our ADRC network. All of that had to be addressed. Technology was mentioned earlier. When you're talking about an organization of less than 20 FTEs, bringing our communications and database up to a standard was certainly a priority. So really kind of doing a full scope assessment of where we were as an organization. And that was 5 years ago, and we're still kind of building on that. And again, going back to the incremental steps, I do want to say that, and the opportunity to work within the ADRC network to explore CalAIM is tremendous, because you have the strengths of both the AAA and the Independent Living Center. You have different sized organizations with different skill set, but working towards those core services of transition, options planning, short-term service coordination, information and assistance, all of which influence the social determinants of health, all of which are opportunities to build into the CalAIM enhanced care management and opportunities moving forward. So just, if there's a place to start, again, I think look at your emerging or designated ADRC, start conversations locally with your, community partners. In Marin, there is a CalAIM stakeholders coalition where CBOs, the county, our federally qualified health centers, our homeless service providers are meeting monthly to explore how we, in a relatively smaller, you talk about economies of scale, county of about 260,000, how we can position as a network to take advantage of CalAIM. And that really has to be coalition, just based on the size and capacity in our community.
Thank you for that. Michael, I see your hand is raised. Did you want to add to this conversation?
Yes, actually, just I wanted to riff a little bit. Am I on? Sorry.
You are, yeah.
Telling me I'm muted. I wanted to riff a little bit off of what both Eli and Christy said around cost, actually, and really understanding the cost. Eli said, mentioned the data side, which is really one of these areas that can become a sinkhole. And so it is really important to understand the cost around requirements that you may have to meet around data reporting. There's even these hidden costs around HIPAA compliance and insurance and liability and all this other stuff that comes into it. And so I just suggest that before anyone gets involved in the request for PATH funding, that they really understand what it is they need help with in terms of their infrastructure build.
Yeah, that's a great call out, Michael. And I'm curious, maybe, I don't know, Christy, others, how does somebody figure out what that list looks like of all the potential costs so that they could say, all right, I got to start to really unpack what are going to be my requirements and like Michael said, the associated costs.
As Michael was speaking, I was looking through the Aging and Disability Business Institute website because I'm thinking, gosh, they must have a checklist on this. So that is something that I'm going to look for. And Sarita, if we can follow up with everyone afterward, there's a lot of resources, and Anwar probably has things like on the top of his head. But I know the Business Institute has materials around what are the hidden costs, as you noted, beyond what the service delivery costs are that are going to drive up the overall price tag.
Yeah, Anwar, any additional thoughts on that?
Yes, and Chrissy, we can provide you with some of our bullet points, but yes, it really has a lot to do with the writing of the software, the outreach and hiring of staff, onboarding them, and the just the whole staff training, because we really want them to be ready after a thorough onboarding process. The IT equipment, not only just laptops but also the actual software systems that we all need to ensure that our staff have the appropriate security licenses in their laptops and access to their email systems. I mean, we do have a list that we can definitely share, and but you have to really do. I think Eli mentioned this, the whole self-assessment, and we've done it plenty of times because we've scaled up to accommodate the needs for managed care health plans before. So we really have a formula that includes everything I mentioned earlier, including the office equipment and any travel expenses that may be incurred during this onboarding process. So you have to really outline and think of everything that your agency may need before you go live.
Yeah, thank you for that. Well, we actually have a couple of folks who raised their hand, and if I'm going to call on them, and hopefully we'll get them to pose their question or comment to this panel. Let's start with Lilibeth Navarro. Are you able to unmute yourself? Or do we?
Yes.
Great. Please introduce yourself and please pose your question.
Okay, I posted my first question earlier. Oh, where did I go? Okay, but then I have a succeeding question. The first one had to do with what I saw among the slides, which is tagged as 2023 as the year there would be this enhanced services for people coming out of prison. And I don't know if you read that. I wrote it as a Q&A. So that tells me that there would be prior discussion and planning for how to enhance that, because as an ILC, even from the get-go, we would get occasional letters from people coming out of prison, and we had our core services, and that was it that we could offer them if they as much as even visit the center or provide a number we could call them. So we're interested in that because they're also among those that need the most help as they mainstream back into society. And then I'm also worried about if we were to have a healthcare GPS and we have all these alphabet soup, you know, there's CalAIM, there's ADRs, and there's all that. And from this level where we are, we can define, we can talk about all the services that we have. I'm a little worried about the regular population and how they get to hear about all this. These are wonderful things, but they're like jewelry encased in glass boxes that you have to see only in the store. So how do we get to them?
Yeah. Great questions. Thank you. And comments. I think you highlighted, I mean, you know, the complex population you outlined, you know, coming out of incarceration. I mean, I think we you know, definitely more opportunities to enhance that coordination effort. And then the acronyms and well, two things, I think, you know, just having the similar language. I know Ben talked about, we have the same language, but we say it different ways, but it's still important to clarify that. And how does the general public start to understand what all these systems, acronyms mean? So I think we have some work ahead of us. And I know, you know, the Department of Healthcare Services and the California Department of Aging, others are actively working on those public communications. And I don't know if others on the panel have anything to add to Lilibeth's, you know, comments or questions. But I think thank you for bringing those up. Great. All right. Yeah, Eli, were you going to say something?
Yeah, just, you know, I think Elizabeth makes some really great points around not losing, and I'm interpreting it as not losing your identity as a local service provider as you pursue these other opportunities. And, you know, I think it's really taking it from a framework of how is this moving the needle on equity for the clients that you're already serving and the clients that you could be serving. And some of this work does require additional skill building, alphabet soup, and kind of going back to school to build your capacity to speak the healthcare language. But ultimately, at the end of the day, it's about raising the level of equity for our community, for our older adults, people with disabilities, caregivers, family members, and ensuring that, you know, not only do they have better health outcomes, but because they have better health outcomes, they're more likely to successfully secure housing, gain employment, connect socially in the community, connect with family. So kind of like taking the complexity of the healthcare lingo and turning it into our language and reclaiming that, I think is part of the process to explore.
That's great. And actually, Heather Wankin said, you know, thank you for sharing. ILC integrative living life center. I thought that was so, which is not how we're describing ILC. Do you want to speak to that, and just remind folks what ILC stands for?
Yeah, I apologize. I've been in my field for too long. Independent Living Center or Center for Independent Living. We go by both.
Yeah, yes, thank you. So yeah, it's a great call out to all of us. I mean, we all are subject when we get very comfortable with our own, we have our identity, but we need to ensure that others understand who we are and what we represent. So that's great. I think the other hand up, if we could ask Katie Krull, if she'd be willing to unmute herself and ask her question or pose her comment.
Yes, good morning. First of all, thank you so much for everything. It's amazing discussion and helps a lot. I apologize if my question is answered, but I'm still a little bit confused. I understand that CBAS is the component of CalAIM, right? Because it's a Medi-Cal Managed Care benefit. However, I don't understand if CBAS is one of the resources or CBAS would be additional service to CalAIM. Could you please explain that?
Does somebody want to, CBAS is community-based adult services. Does anybody want to maybe help to answer that, maybe Anwar?
CBAS and ECM can complement each other. They can be duly enrolled, and I can provide the link to that. I put it earlier, but it is a, there you go, there's a link. It is a benefit that is not necessarily excluded in the participation of ECM. And what I mean by that is, if I'm enrolling someone in enhanced care management, but they're in another waiver like MSSP or HCDA or assisted living, they cannot be duly enrolled. But they can with CBAS, so long that you're not duplicating any of the complex care management or intensive care management services. So it kind of it actually complements the services that CBAS is not providing out in the community.
Great. Thank you. Thanks for the question, Katie. I think that was a really important question for the audience and for the panelists. We have a few more minutes, but I have a few more questions from audience participants. There was actually a very good question from Michelle Nevins at the Caregiver Resource Centers. As a community-based organization, a few of the healthcare settings have reached out to us, and this is the Caregiver Resource Center, to provide caregiver respite services. However, the reimbursement rates are lower than the hourly rate of in-home care agencies we contract with. There was some mention of incentives. However, it is not clear to me what those are. Can you shed any light on the reimbursement rates for CBOs to make it worthwhile? Who would like to take that on? I don't know if, I know we touched on this, but Christy, I know I don't want to put you on the spot. I know it's a hard one, so maybe we don't have a direct answer to this, but how do we get to that, to answer that question? Because I don't think this is going to be the first time we're going to be posed a question such like this. So anybody have thoughts on this? Or I think we have to circle back on this. I don't think I have an answer to this kind of complex question, but I think we have some work to do to kind of help you think about that in terms of the incentives and how do they shed any light on the reimbursement rates. But I don't particularly have that answer right now, but it's a great question. We'll definitely circle back, and maybe some of the future webinars or other discussions can really start to elucidate that. Or maybe, Christy, I'm wondering if the Aging and Disability Business Institute might be able to, take this on.
And one of the things that I was thinking about more broadly, so it's not specific to CalAIM or to caregiver supports, but one of the things that we've been thinking about more broadly is the aging networks and the disability networks' ability to braid funds to holistically address an individual's needs. So, you're taking various pots of funding, so whether it be Older Americans Act, let me get my title right here, Title III-E services that I think address caregiver supports or respite support, and then some other funding that maybe is coming from CalAIM. So you can braid those resources together to holistically address those care needs. Not saying that that's an ideal model, but I think, That's for one specific service. We've been thinking about it more from a care coordination, SDOH assessment approach. So if an individual is referred from a health plan and the health plan is saying, well, we'll pay for X services. But then through that assessment, it's determined that they need X services plus Y and Z services. Then what are some of the other funding streams that can be brought to bear to make sure that those needs are met and Y and Z services are also delivered? And that is an area that the network does have skill in looking at, are there community development block grants, Older Americans Act funding, what are those various sources of funding that can be brought together? So that's a higher level answer, not as direct a response to the question, but I did want to put that on the table.
I think that's a great comment. And, somebody from the audience even said, I think Jerry Lalonberg said, braid concept is great and natural. So I think there's more to explore or unpack on that one. So I know there's more questions, comments. Definitely, I first and foremost want to thank the audience for their insightful comments, questions. And we'll do some follow-up, or we'll talk offline about how to address some things that maybe weren't clarified. I know that I appreciate the panelists for offering information in the chats, and really just want to thank the panelists for their leadership, their commitment, their passion in this space around partnerships, community supports, whole person care. And so with that, I'll just say thank you for your commitment. And I think now I am being asked to turn it back over to Sarah for closing comments. So thank you, and thanks again.
Thank you so much, Sarita. You did a fantastic job kind of weaving in all the different comments and remarks that we heard from in chat and on the Q&A. We're definitely keeping track of everything that we heard today, and we're going to pass back the feedback to our colleagues at DHCS. Really what we want to hear from you is, what would you like? How can we be helpful in advancing this conversation? So this was just the start, but we are very committed to continue exploring and engaging in this issue. We think that this is a tremendous opportunity and a tremendous time for our aging and disability networks to partner together and with other providers in the community to really build out a more person-centered delivery system. So thank you to you all, and thank you for being here. And I want to hand it over to Amanda Lawrence, the project director of the Master Plan for Aging, who's going to talk a bit about our next upcoming webinars.
Hi, yes, thank you to everyone who attended today, and we're excited to share that we will have a monthly webinar with a fantastic panel like we had today. The bar is really high. Next month, we will focus on skilled nursing care, and we'll talk a bit about the Biden-Harris administration's new steps to improve the quality and safety of nursing homes and to protect vulnerable residents and healthcare workers, and what that means for California. In May, we'll talk about advancing age-friendly health systems. And then throughout the year, we're going to touch on topics like Alzheimer's and dementia, community engagement and volunteerism, equity and data, climate change and emergency preparedness, disability, employment and awareness, and caregiving. And then in December, we'll actually recap the first 2 years of progress in the Master Plan for Aging. We always post the materials from the webinars online. You can find them on CalHHS's MPA webpage. And then our recordings are always posted to CDA's YouTube channel. So if you've missed a webinar in the past, go ahead and check out our YouTube channel, and we'll continue to post our webinars moving forward. So thanks everyone for being here. And you can always send questions and comments to that engage@aging.ca.gov mailbox about the Master Plan for Aging.